Good afternoon, everyone. Welcome to this afternoon's echo session. And my name is Kozi Ziambo. I will be the facilitator for this afternoon session. You might want to note that we have been joined by Copperbelt, Central Province, Northwestern Province, Luapula, Muchinga, Northern Provinces. So today is when we are having a provincial-led echo. And so we know very soon that we will be transitioning some of these roles to the provinces from where the provinces will be able to lead their own echo. We had a wonderful time in the last 2 weeks visiting your provinces. Different teams have visited the provinces to try and strengthen your echo and set up sub-hubs over there. So we thank you for your warm welcome, and we appreciate that you are very zealous to carry on with the work of ECHO. So, but for today, we will be together and we'll be able to share our ECHO session for today. In the coming months, we will be expecting as sub-hubs in the different provinces. As we go along, you will be able to run your own ECHOs at least once in a quarter. So today we have an interesting session. We'll be looking at DSD and retention to care of those people living with HIV and our care and treatment. But before we go into that session, we have got an important announcements that we'd like to make. And so we've been joined by the Lusaka Provincial Health Team. They have got a presentation that I would like to share with us. And so they'll be joining us. The Provincial Health Director from Lusaka, Dr. Konseti Mwale, will be sharing something related to COVID. And then from there, then we'll pick it up with a DSD presentation. So just to make sure that we have people who have connected, I'll just call out some people and just so that I can say hello. Lewanika, Urban Health Center, I see you're connected. Are you able to say hello? Good afternoon, Lewanika. And you're supposed to actually be joining the Western Province link. I've seen that most of the people here have joined the, is this from Eastern Province, you're with us? They haven't shared with you the Western Province link. Okay. So can we also hear from you? I've seen here there is Dr. Ziko Lunga. How are you doing, sir? Dr. Ziko, can you hear us? Can we hear from Arthur Davison? Arthur Davison, I see you're connected. Can you say something? Just to confirm if you're able to hear us.
Oh, okay. I see that.
Oh, I've seen that the host, you will be able to be unmuted, so I think we'll resolve that. Oh, great. Okay, so Dr. Ziko.
Oh, finally. Good afternoon.
Good afternoon. Good to see you. Logged in.
Thank you.
Thank you. You're welcome. So Arthur Davison Hospital, are you connected? Maybe we could also hear from you. So they're not be able to hear us. Okay. Okay. So Lusaka Provincial Health Office, are they connected in?
Yes, we are.
All right. Thank you so much. Are you able to share your slides so that we can proceed?
I'm not able to, but you can share for us, Dr. Ziambo. I've already sent to you on your email.
Oh, okay.
Thank you.
All right. All right. Thank you so much. I've noticed that we have been joined by Eastern Province, some facilities from Eastern Province, some facilities from Southern Province, and also some facilities from... So I just wanted to encourage you to rejoin. Don't rejoin your echo in your provinces, because this one is for the the northern region provinces.
Dr. Jambo, good afternoon.
Afternoon, Dr. Mumba. How are you?
I'm fine. Apparently, other provinces haven't started hosting. We are still waiting for the host to start, particularly for Western Province.
Oh, okay. All right. So I'll ask the IT to pick it up and try and assist them to open Western.
Dr. Ziambo, even Lusaka hasn't started yet, I think. I tried to join their group, but it wasn't there.
Oh, okay. So we'll work with the IT and see that they open.
He's seen a loophole. And according
Okay, so I have just confirmed
as a result of
All right, so we are requesting the team that have joined in to keep their mics on mute unless you've been asked to connect. So Lusaka province should be able to open now. We've confirmed. We're just trying to work with Western Province. We'll see if the IT is working with them, see if they can open. Thank you. So Chatonda, have you been able to share the slides? So, Dr. Msiska, you'll be the one presenting this particular.
I was hoping PhD. He's not yet on the call, but if he's not yet on the call, I can present.
Okay.
Kindly share for me.
Yeah, I'm still trying to get hold of the presentation.
maybe you can download it from the
I use your email.
So apa? I'm talking. Digital new.
Okay.
All right, thanks.
I can go ahead, Dr. Ziambo. Dr. Ziambo. Dr. Ziambo.
So, Dr. Siska, you
Dr.
can
Ziambo.
proceed and start presenting. Thank you so much.
Can mute their mics. So good afternoon, everyone. This is Dr. Sophia Siska from Lusaka Provincial Health Office. We just wanted to to share our COVID-19 vaccination implementation and strategies in Lusaka province, since we're the first province to receive the vaccine. I'm doing this presentation on behalf of Dr. Constantine, our PhD. Next page, please. So for the COVID rollout, what is required is to make sure that we have the national COVID-19 vaccination field guide, which all of us are going through right now. And then copies of the micro planning and spreadsheet and the tools, the micro planning for all the districts and all the facilities. Then we also need to have the monitoring tool, which is the COVID-19 vaccine register, summary sheets, supervisory checklist, the vaccination card, and the IFA notification form, and also the COVID-19 vaccine certificate. And then for the adverse event following immunization management kits, it's basically just the emergency tray that you can use in case someone has anaphylaxis. Then the vaccine vials and syringes, and then we have to make sure that we have the supplies, that means sanitizers, face masks, hand washing facility as we are vaccinating patients, clients. Then we also need to make sure that we have the tool boxes and the vaccine carriers. Host, kindly mute the mics. Next page, please. Next slide. Yeah. So the implementation process for Lusaka, we started our vaccine launch on Wednesday last week when the Minister of Health launched the rollout. So, and following that, we've made sure that we've identified space for storage in all the districts and health facilities that will be handling the vaccine to make sure that the vaccine characteristics, cold chain requirements, and handling principles are met. And then also training and orientation process of the vaccine administration and infection prevention, control, and measures are being done. And this is also ongoing. So we started our online presentation training on Thursday, Friday, and Saturday. So it has been ongoing and making sure that all the facilities are being trained. And then also we are using a training on the utilization of the recording and monitoring forms that are being which is being done, and it's ongoing by M&E. And then also orientation on how to identify the adverse effects following immunization and how to report these adverse effects on the cases is also ongoing, because some people who have already received the vaccines have already gotten some minor side effects like headache, maybe muscle pain and pain around the side. Next, please. Next page.
Let's just say about
Next page, please. Yes. So orientation on also how to identify this process has also been going on, and how to report and manage the cases is also ongoing, and making sure that some of the side effects are also included on the vaccination card. Then demand creation among health workers, support staff, and priority groups is also being done and also ongoing. Then sensitization on COVID-19 vaccination programs is also being done and is also ongoing on all the available platform, be it media or physical. And also demonstration on effective communication about COVID-19 is also being done and is also ongoing. Next page, please. So the strategies for rollout. So our rollout is in a phased approach. We started off with UTH, which is our main center, and then rolled it out to the other facilities such as Levi Mwanawasa and the other districts. And then we're also going to make sure that the mobile sites are also set up so that we avoid service disruption. Then in the hospital settings, we're making sure that the different units are also being vaccinated and being followed to the different units so that the service disruption is service is not disrupted. Then there's also on-site training of administration of the vaccine at private health facilities, the training institution workers and the lecturers are also vaccinated. And also set up of mobile sites where we can go to a facility and make sure that the health workers are also being vaccinated. And then we're also doing a tracking system to make sure that the consumption of the vaccine and active pharmacovigilance, and also daily reporting on the program. Next page, please. So the priority target, we have been set that the essential health workers and support staff are the target, and making sure that all the doctors, nurses, pharmacists, everyone who works in the health setting is making sure that we are vaccinated, and also making sure that the other society function, the core people like the police, immigration, teachers, lecturers are also being targeted in this group, as well as we are rolling out the vaccine and implementing. Next page, please. So these are some of the adverse effects we need to look out for. This is something that can happen after receiving immunization. You look to look out for the pain, soreness at the injection site, headache, fatigue, muscle pain, joint pain, and fever and chills. Those are the minor ones. Next page. And then the severe one is the anaphylactic reaction, which can occur in 1 in or 5 people in a million, but it's severe and potentially fatal, and it can react. It can happen after 5 to 30 minutes with acute onset of symptoms, and then we need to make sure that we look out for this. There could be urticaria rash, there could be bronchospasm, laryngeal edema, GI symptoms, and hypotension and shock, and dizziness or syncope. Next page, please. So we need to make sure that the kit for the adverse reaction is available. Make sure that the adrenaline is there, IV cannulas are there, IV fluids, and making sure that everything is also available, and the patient should be immediately sent to the nearest hospital. Next page. And the challenges that we're facing is inadequate understanding of the tiers that need to be vaccinated, the priority people in the initial phase, and then also inadequate identification of the clients. And then there's also apathy among the healthcare workers, which we need to improve, inadequate data capturing tools, which have not been available, but are also being made to roll out. The network challenges, and also lack of ownership by some program officers in the management in the facilities, and also inadequate sensitization among health workers. And we also need to include the IC materials. Next page. Next page. So some of the mitigation processes is LPHO has generated a memo to all heads of unit institutions and THDs to prioritize groups to be vaccinated in the initial phase, strengthen sensitization and vaccination programs, and also decentralization of the vaccination points, not just UTH, but all the other facilities. Then a redistribution of laptops and personal phones, and also technical support to all the management in respective facilities. Next page. So, and these are some of the recommendations we've used to make sure that the MOH expedite the distribution of data capturing tools, IEC materials, invest in radio and TV sensitization programs, inclusion of the IFE and on the vaccination card, and provide counseling for clients who on expected side effects, and also share the toll-free lines to the public in case of any adverse effects. Next page. This is my last slide, and just to say that COVID-19 is important for the protection from COVID-19 infection, and we should also ensure that we're following the national guidelines and recommendation on COVID-19 guidelines. The 5 golden rules still remain, and the cold chain needs to be maintained between the 2 and 8 degrees so that the vaccine is effective. Thank you very much. That's the end of the presentation.
Thank you so much. Thank you so much, Dr. Sophia. We do appreciate this initiative and sharing experience and the best practice for the rollout for the vaccine. And I'm sure the provinces have taken a keen interest and have learned 1 or 2 things. Thank you very much. At this particular time, we'll now move on to our session. Thank you very much. We'll straight ahead go to our session, and we'll allow Dr. Mlenga to just introduce herself, and then you can proceed to sharing a presentation. Good afternoon, Dr. Mlenga.
Good afternoon, thank you, Dr. Ziambo, and good afternoon, everyone who has joined in. Thank you.
Welcome to the session. Thank you very much for joining us. We now are ready to listen to you as you share this afternoon's presentation. Thank you.
Okay. I would like to thank the ECHO team for having given the DSD team an opportunity to give this presentation. So I'm giving this presentation on behalf of the DSD task force. As I've been introduced, my name is Dr. Priscilla Mulenga. I am the DSD National Coordinator, and I also wear another hat where I am the PMTCT National Coordinator. Okay. We can move on to the next slide. These are the learning objectives for this session. Basically, we are going to define what DSD is. Okay, DSD stands for Differentiated Service Delivery. We are going to present an overview of the DSD models. We are going to look at the benefits, and we'll discuss DSD in children, and we'll end with a brief outline on the program implementation. So this is the first poll question. The statements below are correct, except is it A, differentiated care is an approach that is facility-centered. B, DSD models have potential to improve efficiencies and decongest health facilities. Then C, how is not one of the DSD building blocks. Then DSD can be applied across the cascade of the UNAIDS 1990 targets. So which one is according to the statement?
Thank you so much. So we are inviting the network to poll to pick which one is not the correct one here. So the statements below are correct. They are all correct except one. So can we identify that one which is not correct? Is it A, B, C, or D? So you can see there's a poll question there put, and you can just click on the what you think is the best answer. So far, the participation is all right. We have about 44% that have polled so far, and most people, there's a variable. The answering is variable. Some think it's A, some think it's B, some think it's C, and some think it's D. So, Dr. Mlenga, we have quite a bit to explain here, because the selection is quite variable. I'll share with you so that you see how the people have polled.
I'm also following with what you have put on the.
Okay, all right. You're able to see, eh?
Yes, I'm able to see.
Okay.
At least all the options some people have responded to.
Yeah. So we have a few seconds, just 10 seconds more before we end the poll. Please pick your best answer. Okay, thank you. I'll end the poll here. And then let's see how, I'll just show you how people have fared. And sorry, it's taking a bit of time. So this is how people fared. Most people think A is the one that is an exception. A few think B, a few more think C, and some D. But anyway, we'll learn as we go along. So we'll proceed, Dr. Mlenga, to the next slide.
Okay. So it is very important that we start by defining what DSD is. Okay, so for this, we are going to define differentiated care. And I should make mention that this was adapted from the International AIDS Society 2016, lest I'm cited for plagiarism. So the way we define differentiated care is the patient-centered approach. I'm sure you are now relating to the poll question, okay? It is not a facility-centered approach. It is a patient-centered approach, and this approach simplifies and adapts HIV services across the continuum of care to reflect the preferences and expectations of various groups of people living with HIV, and at the same time, improving the efficiencies of the health system. So from this definition, what we should take home is that it is a patient-centered. Okay, we have put here patient-centered because that's how the definition is in the article where we got this definition. Otherwise, we are avoiding saying patients. We call them recipients of care. Okay, so for this definition, we have put patient-centered because we have just copied and pasted the way it is from the original definition. So we are saying it cuts across the continuum of care. So DSD is not just about ART. You can apply DSD for the first 90, which has to do with testing. DSD can be applied to second 90 to do with ART, and also to the third 90 to do with viral load suppression. So we know that most of our DSD models lean towards the second 90, but DSD can be applied to all the other, to the continuum of care along the cascade. So why DSD and why now? Okay, they increase the recipient of care, okay, volumes in the health facility, because with HIV care, we enroll and we do not discharge, okay. So they increase the recipient of care volumes in the health facility without a matching increase in the human resource, has resulted in an overburdened health workforce. People from the facilities can attest to this, and this increase has been attributed to the scale up of HIV testing services to increase positivity yield, as well as the adoption of the test and treat strategy in 2016. So you find a situation where you have the health facilities are being overburdened with patients, with recipients of care. Sorry about that. Yeah. So with this background, DSD simplifies and adapts to the needs of the recipients of care and serves as one of the ways of decongesting the facility. Okay, so that's why DSD is being promoted. Let's move on to see what the building blocks of DSD are. Okay, so the building blocks, if you follow with me, they are what? Okay, even before I mention them, we should see that the recipient of care is at the center. This is very important, okay? So we do DSD because we want to meet the needs of the recipient of care. Whatever we do under DSD, we need to have the recipient of care, okay, in mind. It is for the benefit of the recipient of care, okay? So it's a recipient of care centered approach. Looking at the building blocks, you have the what. Okay, basically you are defining what are you doing in that DSD model or in that differentiated care. Okay, you have the what, you have the who. Okay, who is doing what? Okay, is it a physician, clinical officer, the nurse, the community people, and whoever? So you need to define the what, the who, where. Okay, we have models that are appropriate for the facility. Other models are appropriate for the community. Others, they combined both the facility and also the community, and also when. Okay, so the when is about, is it monthly, and what is happening during that monthly visit? Is it every 2 months, 3 months, or 6 months? So all these things in every model, they need to be defined. And let me also add on to say that whatever model, it should be in line with the prevailing guidelines. For now, we are following the 2020 Zambia Consolidated Guidelines. We know that every 6 months, a recipient of care should come to the facility for lab and also clinical monitoring. So in whatever DSD model this recipient of care is, every 6 months, they need to come to the facility for lab and clinical monitoring. No DSD is allowed to deviate from the prevailing HIV guidelines. Next slide, please. So the second poll question, should I read or people are able to read?
No, you can go ahead and read, then I'll just try and share the poll questions.
All right. So that is for, what you are sharing is for the first poll, okay.
The second poll question.
So select the odd one out from the following statements. Depending on their needs, all people living with HIV in Zambia may be eligible for DSD. Then B, DSD is only applicable to the stable recipient of care. Then C, viral load suppression below 1,000 copies per mil within the last 12 months is an eligibility criterion for 6 months, multi-month scripting and dispensation. Then D, a recipient of HIV care with controlled hypertension can be enrolled in a community adherence group, a DSD model.
Thank you so much.
The question
Thank you
is,
so much.
select the odd one out from the following statements.
Thank you so much. So we've put the pause out there so we can select which one we think is the odd one out. Is it A, depending on the needs of all people living with HIV in Zambia may be eligible for DSD? B, DSD is only applicable to stable recipient of care? C, viral load suppression below 1,000 within the last 12 months is an eligibility criterion for 6 MMD? Or is it D, a recipient of HIV care with controlled hypertension can be enrolled to a community adherence group DSD? Which one is the odd one out? So let's keep checking in on those answers, which one is correct, so that we can move to the next slides. So that, so far only 50% have voted. Let's participate. Let's get involved and engaged in this session. They say learning, usually it's, if you're involved in the learning process, there's much more retention. So we invite you to participate. Okay, so I think I'll end the poll here and then share the results. Thank you everyone for participating. I'll just share the results with you so we'll see how we are doing, how we performed. Most people thought B was the odd one out. We still had a few who thought A, C, and D. So that's our results, Dr. Mlenga. I think we can move on to the next one.
So much of the questions, a number of questions from the second poll, I think was testing on the eligibility criteria. Okay, so this slide is just now leading us into the next. Okay, so the recipient of care classification for differentiated care. So if you follow with me this chart, you have people living with HIV on top, okay? Then these ones, from these ones, you have some who may be, who could have been on treatment for more than a year. On the other side, on my left, you would see that some people may just be newly initiating on ART or on ART for less than a year. If we go for those who've been on, for those who could have been on ART for more than a year, you can see that some would be what we call stable. Others, they may be regarded as unstable. And then this term actually, people have issues with it, the term unstable. So we prefer actually saying people at high risk. Okay, not being stable, unstable, but at high risk of disease, of HIV disease progression. So that's one arm. For those who've been on treatment for more than a year, we have the stable and the unstable, the people at high risk of disease progression. For the newly initiated on ART or those on ART for less than a year, we have those with early disease, okay? And then we have those with advanced disease. Next. Next slide. Yeah. So from that, what do we get? We are saying that all people living with HIV in Zambia may be eligible for DSD dependent on their needs. Remember, from the definition, we are saying we are simplifying and adapting to the needs of people living with HIV, and that can be applied across the continuum of care. So stable recipients of care are eligible for both facility-based models and also community-based models. Okay. Then it is essential for recipients of care to be made aware of all the models that are available at a particular facility. Okay. You can't find all the different kinds of models that we have in the country at one facility. So the available models will be different from one facility to the other. And it is important that we make that known to the recipients of care. Okay. So facilities should only implement the models that are feasible in their settings. Okay, we can proceed. Yeah, let's now look at the stable recipients of care. Okay. So this is how we define a stable recipient of care. So this is applying to adults. And by adults, we are saying more than 15 years. The first one, someone should have been on ART for at least 12 months. So if we go back to slides, you will see where it said the flow chart that was differentiating people living with HIV. Okay, we have those on treatment for more than 12 months and those on treatment for less than 12 months. So we are focusing on the right side of the flow chart with on treatment for more than 12 months. The second one, it should be no adverse drug reaction requiring regular monitoring. Okay. The third one is no current illness requiring regular monitoring. Then they should not be pregnant or breastfeeding. So we have excluded the pregnant and breastfeeding women as being defined as stable. But remember, they can be differentiated into a different kind of care, but not as stable recipients of care. Then another criterion is they need to have proven record of good adherence and treatment success. The viral load suppression, it should be, of course, we know what is supposed to be 1,000 copies per mil within the last 12 months. So we only need one result, not two. Okay, only one is sufficient within a year. And then those with non-communicable diseases, okay, as long as the NCD is controlled, they can also be enrolled in a stable DSD model. Okay, next slide. Yeah, so we are looking at the stable DSD models. So like I mentioned, we have stable DSD models can be at the facility. They can also be in the community, okay? There we are saying all people living with HIV in Zambia may be eligible for DSD dependent on their needs, okay? So some models will be in the facilities, others will be in the community, okay? For the facility-based models, we are able to appreciate, those are just like few examples: multi-month scripting, fast track, facility-based ART groups, okay? Then for the community-based models, we have community ART groups and ART distribution, home ART distribution, okay? And then for all these models, they can either be led by the recipient of care themselves, okay? They can be empowered to lead these models, or some of them can be led by healthcare workers, okay? So either some can be led by recipients of care, others by healthcare workers, depending on different settings. Next slide. Yeah, so now we are just now having an overview of the facility-based DSD models. Yeah, So what is highlighted there are the facility-based models. We have the urban, okay, adherence groups, okay. It was called urban because it was initially implemented in an urban setting, but that does not mean that we cannot have a rural, okay, version of the urban adherence group. So we have urban/rural adherence group. We have the fast track, we have the multi-month scripting, and we have the before or after hours. Those are just some of the examples under the facility-based DSD models, okay? So in detail, this is the initial concept of the fast track, okay? Remember, all these models that I'm talking about are stable DSD models. Only those who qualify, you know, we went through that list. A recipient of care should qualify, okay, or that is listed, okay, on that list, okay, everything, okay. They should be, if they have a non-communicable disease, that non-communicable disease should be controlled. They should be on ART for more than 2 years, and no side effects, no intercurrent illnesses. So fast track is one of the DSD models for the stable recipients of care. So basically it is in pictorial form and very easy to understand. A fast track pickup is an accelerated pharmacy pickup. Okay, mostly it's accelerated pharmacy pickup for stable recipients of care. Okay, so every 3 months, the recipients of care come to the health facility to receive adherence counseling, and they collect their ARVs from the pharmacy. So these are stable recipients of care. They've just come for a pharmacy pickup, but we know that adherence has to be emphasized at every opportunity. So this is expedited. They go to the pharmacy, they collect, but adherence has to be done. They do not have to queue for them to get the drug pickup. Then every 6 months, recipients of care come for their full clinical visit. They receive adherence counseling and collect ARVs from the pharmacy. So when they come just for the drug pickup, that visit is expedited. But when they are coming for at a 6 months visit, they need to be evaluated according to the guidelines. Okay, next slide. Yeah, and then the urban and rural adherence group. So this kind of a DSD model, it's a group model, but based at the facility. This is implemented at the facility. So you have this huge group of 30 or more, of up to 30 stable recipients of care, usually from the same community. Okay. Then every 2 to 3 months, the members meet at the clinic for adherence, support, symptomatic screening, and drug dispensation. And this group can meet during the working hours or even after clinic hours. Okay. Then every 6 months, the recipients of care, they go to the clinic for a full clinical visit. However, they continue to collect drugs in their groups. Okay. So our observation has been that with the introduction of the 6 months multi-month scripting and dispensation, most of these groups are being affected because people are preferring the 6 months multi-month scripting and dispensation. But there's a way in which all these groups can be modified to ensure that it is responding to the needs and the concerns of the recipients of care. Next slide. So we were looking at the facility-based DSD models. Now let me take you quickly to the community based DSD models. So for both, you can have healthcare worker managed or client recipient of care managed models. So the famous CAG, okay, is a good example of a community group model. Then others, you have the mobile ART, home delivery, the CDU, community retail, health post, and the list is endless. Okay, next slide. So this is giving us more detail on the CAG. Okay, so ideally, or the standard, let me say the standard, not ideally. The standard is a CAG is a group of 6 stable recipients of care from the same community, preferably. Each month, one member of the CAG goes to the facility for their routine clinical visit. So that member would be going to the facility because it's their 6 months visit, usually. Okay. Once they complete their clinical visit and they pick up a pre-packed and labeled bag with a month's supply of ART drugs from the pharmacy for all members of the CAG. With the bag of ART drugs for the group, the CAG member travels back to the community. Back in the community, the CAG group meets at a location of their choice for symptom screening, adherence, and everything, and distribution of ART drugs to all members. The following month, another member takes it up and the cycle repeats itself. So this is the original concept of the CAG. Of course, again, it can be modified to meet the needs. If the group agrees that we should be doing every 3 months, at least we pick up for 3 months, and the facility is in agreement, it can be modified. Okay, but again, it's something that the DSD task force should be made aware of. Okay, this is another community DSD model. Okay, let me also mention that most of these models were adapted from the partners that were implementing. So they are no longer like this model belongs to this partner. These are now national DSD models. Okay, so a certain partner could have invented, or at least could have been the first partner to have implemented in the country, but the way it is as at now, these are models that have been adapted and they are considered national DSD models, and every partner is at liberty to implement these models. Okay, so this one is basically a home distribution. Okay, I always say, when I become a recipient of care, if I happen to be a recipient of care, this is the model I would opt for. Why? Because the drugs will be distributed to my home. Okay, so as we can see in that pictorial, we have the community health worker who now acts as a link between the facility and the community. Okay, so the community is defined as a geographic area, in a defined geographic area, and the leaders are engaged, sensitization carried out. So the community health worker goes into the community, and what is innovative about this model is they do not go with the registers, okay, where I know there's that risk of breaching the confidentiality. These ones, they go in with tablets, okay, and on these tablets, there's a smart care light, okay, installed on the tablets. And then data is collected. When the community health worker is at a facility, then it is synchronized with the smart care at the facility. Yeah, so this is the home ART distribution, where you have community health workers distributing medication at the home of the recipient of care. Very convenient indeed. Next slide. Yes, this one, even the graphic presentation looks a bit complicated. It is complicated when you look at it, but when you understand it, it is not that complicated. It is called the CDU. We have simplified it because DSD has to do with simplification. Okay, the original name for this model was CCMDD, meaning centralized chronic medicines dispensation and distribution process, but it's simply called CDU. Okay, so
very mouthful, very difficult to remember, Dr. Mlenga.
Yeah, that's why we have simplified it. It's now just called a CDU, centralized dispensing unit. So for this model, remember I said a facility should only implement models that are convenient to their setting. This model requires heavy investment, initial investment, okay? And it is only being implemented in Indora and supported, okay? Supported by a partner, a specific partner, okay? But this model has been adopted as the national model, but it is still supported by a partner in Indora. So the way it works, you have facilities. Recipients of care go to different facilities that have been incorporated into this model. They get the prescriptions. So those prescriptions are electronically transferred to the central dispensing unit. At the central dispensing unit, there's pre-packaging of the commodities. And then the commodities, according to the prescriptions, are then taken to the pickup points. Okay. So the recipients of care collect the ARVs that are pre-packed at their nearest, okay, or preferred pickup points. The beauty also about this, is that the pickup point may not necessarily be a health facility, okay? The pickup point can be even a private pharmacy. Okay? So when you are in Indora and maybe you stay somewhere in Itawa, you can say, okay, you can choose, okay, I want Link Pharmacy at Jacaranda Mall to be my pickup point. So with your prescription, you only go to the facility for you to be examined, but the prescription will be sent electronically to the CDU, and then you'll be informed when to pick up your commodity at Jacaranda Mall, at Link Pharmacy, or whatever direct pharmacy, or whichever, okay, facilities have been incorporated as pickup points. Yeah. So this is the CDU. Okay, it looks complicated, but it works well. This is another model that I can opt in should I become a recipient of care. Okay. Next slide. Yeah. So all those models that have that have been talking about up to this time are stable models for stable recipients of care. But we are saying everyone who is living with HIV can be differentiated, okay, can receive differentiated care. Okay, so there are models for the stable clients. There are models also for those who are at high risk of disease progression. So this is the criteria. So when one has, when a recipient of care has only one of these, then they cannot be considered as stable. They are unstable. Okay, so on ART for less than 12 months, any recipient of care presenting with advanced disease, you examine these recipients of care and you find they're in stage 3 or 4. Any recipient of care presenting with severe immunosuppression, you do a CD4 count and it's less than 200. Any recipient of care not virally suppressed, viral load more than 1,000 copies, adverse drug reactions requiring regular monitoring. Although just having one of them, if you compare with a stable, a recipient of care needed to have had all of them, okay? But for the unstable ones, just having one of these on the list, okay, then they qualify to be unstable and you manage them as such. So the unstable recipients of care may be enrolled into specific models to support their needs. For example, a virally unsuppressed recipient of care may need viral load suppression. And of course, what comes to mind is you're going to put them in a EAC or DSD model. Next. Are we leaving children out? Definitely no. Okay. I have not talked about children, but this is the time to look at children. Before that, let's do the last poll question. The following statement is true. Children are ineligible for month scripting and dispensation. That's A. A child less than 2 years can be considered a stable recipient of care. That's B. Then weight-based dose adjustment in children between 2 to 10 years is very frequent. That's C. And D, DSD has benefits for both the facility and the recipient of care. So let's pick out what is true here. Dr. Kozia, you are there?
Sorry, I was muted and I was talking. Thank you so much. I was saying it's time now for the network to participate and get involved. And so we are inviting you to pick a poll. And thank you so much, Dr. Mlenga, so far. We're picking out lots of important lessons. So which of the following statement is true? Is it A, children are ineligible for MMD? Is it B, a child less than 2 years can be considered a stable recipient of care? C, weight-based dose adjustments in children between 2 to 10 years is very frequent. DSD has benefits for both the facility and the recipient of care. So we are inviting people to participate and pick the best answer from this, what has been put forward here. So we have about 55% of people that have managed to poll the question. So I think we'll end the poll right now so that we can move on to the next slides. So thank you so much, Dr. Mlenga. I think we have ended the poll. We can move to the next slide.
Okay, thank you. Those are the results, huh?
Yes, these are the results.
Okay. We now go on to children. Okay. So we are saying, because of the unique and special needs of children, okay, especially those recipients of care, the healthcare workers have been driven to opt for standalone ART clinic days. for children. Okay. This is a facility-based individual model that streamlines care for children. I know that most facilities now have these pediatric specific ART day. Okay. So this is some form of actually a DSD, because there you are just focusing on seeing children. And if anything, only those who are trained, okay, ideally, let me say, only those who are trained or those who are confident to provide care to a child who is a recipient of HIV care are found, okay, at the pediatric specific ART DSD model. Okay, so this is a good model for children because it enables scheduling of clinic visits during the holiday for school-going children, and the clinical visits are synchronized with drug pickups. Okay. Then those children requiring clinicians' attention, including children less than 24 months, are seen every month. Okay. It is important to realize that stable children, okay, we can have children who are stable, and these are eligible for month-to-month scripting. So month scripting is a stable DSD model. So for children less than more than 24 to 60 months, they are eligible for 3-month month-to-month dispensation. And then for those above 5 to 14, okay, it can vary between 3 to 6 months, okay, month-to-month scripting and dispensation. Okay. So again, remember we talked about the building blocks. The building blocks should apply also to a DSD model for children. So the when, they should be defined, the who, the where, and the what. Okay. So next, the last few slides, I think. Yeah, so how do we define a stable recipient of care? This is a child who is more than 2 years old, okay, on optimal ART for more than 12 months with no dose or formulation changes for at least 3 months, consistent with attending clinical appointments with motivated caregivers, no intercurrent illness, malnutrition concerns, and everything that is highlighted on that slide. Usually our fear has been children. As you see a child, you need to ensure that you take a measurement of weight and then adjust the dose accordingly, okay? But what studies have now shown, actually, next slide. Studies have been done and we have evidence to show that between 2 years and 10 years, okay, the average number of weight-based changes in terms of dose, okay, is about 3, okay. So you can safely actually enroll a child between 2 to 10 in a month-to-month scripting and dispensation model, okay. So in this age group, dose adjustment, okay, may be infrequent, okay, because the average number is about 3, okay. So this is just a graph giving us that evidence that we actually do not adjust so frequently, okay, in terms of dose for a child who is between 2 to 10. This chart is showing us that the adjustments are actually about, if I count, I think 3 or so, okay? So for that a group of children, they can be enrolled in a multi-month scripting and dispensation model, preferably of 3 months, okay? So basically that's what this chart is telling us. So let me quickly end by highlighting the benefits. Okay, these you can read. Availability of variety of models that meet individual recipients of care. Reduced distance to drug collection points. Remember I mentioned you stay in Itawa and you are collecting from Jacaranda instead of going all the way to Chipokota, Mayamba, whatever clinic. Okay, there's improved adherence. If you are in a group, there's that psychosocial support, potentially reduces the HIV-related stigma because these things now are open. You discuss all your fears. You have colleagues, or at least you have your peer to support you in this journey of being a recipient of care. Reduces the number of visits to the facility. A good example is a CAG, and also home ART distribution, and improves retention in care, reduces waiting time for recipients in the facility. So these are benefits that speak to the recipients of care. Let's look at benefits to the facility. Do we have any benefit of implementing a DSD model? Next slide. Yeah, so for the facility, okay, facilitates provision of key services, maximizes on available human resource, economizes on time and space at the health center, allows for more time or for healthcare worker to manage those at high risk, which will lead to improved quality of care, and it contributes to decongesting of facilities. Next slide. Yes, reduced workload on providers on account of reduced patient volumes, because you have you're not asking everyone to come at once. Some people are able to be attended to in the community. Yeah. Lastly, on program implementation, the DSD task force is a body from MOH under the oversight of the Director Infectious Disease that is responsible for coordinating and leading all DSD related activities in the country. We have the differentiated service delivery framework. I would encourage people to read that. And then we have developed the 2020 training package for DSD, and we are actually now rolling out this package. So those are the take-home messages. DSD is a recipient of care centered, remember that? Okay. It aims to meet the needs of different groups, both stable and those at high risk. They can be facility-based or community, and we need to follow the eligibility criteria for both stable and unstable. Then children above 2 years are eligible for multi-month scripting. Then the benefits are not just the recipients of care. Remember, the recipient of care is at the center, but the benefits trickle down to the facility. Thank you very much.
Thank you very much. Maybe before we proceed to the next session, maybe you could just quickly run us through the correct 4 questions
Okay, the first one, I think what was being asked here is to look out for the first one.
Yes.
So what is force here after I have presented? What is force after I have presented? I'm sure now the team can agree that A is force, right? Why is it force? Because we are emphasizing that differentiated care, DSD, should be and is a recipient of care centered, not a facility centered.
Yeah, so we see that statements below are correct except this A is false. And I think, I hope the network is able to appreciate this, because I can still see that the answers are quite variable at the same time.
So maybe I can also go on to explain that why is B,
just explain. Yes,
why
yes,
is
just
B not the
explain.
correct answer? Okay, so we are saying just from the, if you followed the definition, we are saying, okay, it's a recipient of care centered, and at the same time, it improves the efficiencies. So you get that answer from the definition for B, okay? So B is true, okay? Then how? I think I showed the building blocks twice for adults and for children. You don't find the how there. You find a client-centered approach, and you find the what, the where, the who, and the when, okay? You don't find the how. Then DSD can be applied across. I think I mentioned this, that yes, most of our most of our DSD models have some inclination to ART service delivery. We can use it for testing. We can use it for, of course, ART, and also for viral load suppression.
Thank you so much for those clarifications. So we move on to the next 4 question. You can go ahead and read that one for us if you're able to.
So this one, we're looking out for the odd one out. So you needed to read through all the 4 for you to realize which one is odd. Okay, which one is different, basically. So depending on depending on their needs, all people living with HIV in Zambia may be eligible for DSD. That came out clear, yeah? So we have the stable, we have the unstable DSD models. And for those who are newly initiating, we have early disease, we have advanced disease. Okay. Then DSD is only applicable. DSD is only applicable to the stable recipient of care. And usually when we're in med school, once you see the word only, always, you need to be careful, okay? Usually only, always, yeah. So it's not only applicable, I think that was the key there, to the stable recipient, to only the stable recipient of care. You can do an EAC session, that's the DSD model, okay?
Yeah, a viremia clinic is another DSD session.
Viral load suppression below 100 copies within the last 12 months is an eligibility criterion for 6 months multi-month scripting and dispensation. True. A recipient of HIV care with control.
And Dr. Mlenga, and I think there was even a question in the chat where they were asking about someone who, a recipient of care who has been very suppressed just for 6 months, whether they are eligible for 6 months dispensation, or they're considered as stable. So I think maybe this is another explanation to that effect as well.
The question was after 6 months. Remember, yes, if you have to go to the eligibility criteria, we are saying someone has to be on treatment for more than 12 months. Okay, quite all right. If it's a new recipient of care, we are saying the first viral load is at 6 months. Okay.
Yes.
Yeah, with that viral load, they are eligible. But my emphasis was for someone to be enrolled into a DSD model, for which MMSD is, okay, a stable DSD. They should have been on ART for more than 12 months.
Okay.
and they should fulfill all the other criteria on that list.
Well,
That's
yes.
when you enroll them, not just one. If one is missing, then they are not eligible.
Yeah, all right.
I don't know whether I've made myself clear.
Yes, yes, that's very clear now. So we can move on to the next one.
Yeah, so poll question number 2, the answer is B, because that's the odd one out, meaning it's a false one. Then the next one, is which one?
Is this one, poll question number 3? Which statement is
Children are ineligible for multi-month scripting and the dispensation. We are looking for the true one.
Yes, we're looking for a true statement here.
A true statement. So are they eligible, ineligible? Then a child less than 2 years can be considered a stable recipient of care. Weight-based dose adjustment in children between 2 to 10 years is very frequent. Remember, I just finished this section and I said it's infrequent. DSD has benefits for both the facility and the recipient of care. So we are looking for the true one. Which one is true here?
So most people think it's D.
Yeah, so the benefits are both to the facility and also the recipient of care, D.
Yeah. So why are the others not correct?
So you can't just say generally that children are ineligible for multi-month scripting and dispensation. There are some children who are eligible, and we said from 2 to 10 years, actually after 2 years, a child can be considered eligible for a multi-month scripting and dispensation model.
Okay. So thank you very much. We've come to the end of our presentation. And I think these are the references for the presentation. So thank you very much, Dr. Mlenga, for this very informative session. We are supposed to move on to doing a case, but I think in view of the time that we have left, we will not proceed to the case, but we will allow for comments, questions from the rest of the network, so that we may just clarify 1 or 2 things. So I will invite the network to raise their hands so that they can be able to make to ask their questions. Okay, I've seen Monsabombe District. Thank you so much for joining us. Thank you so much for joining us from the police clinic. We thank you for connecting. And also I see Ronald Rose Mufera on the Copper Belt. You also joined in. Do you have any questions following this session that has been presented here this afternoon? Dr. Mlenga is here, very eager to respond to our questions.
Doc, good afternoon. Thank you very much. It's been very clear. A lot of issues have been tackled. Thank you very much.
Thank you. Thank you very much. That's a very important component. I think it helps us understand. At least we've been able to communicate. Monsabombe, I've seen you've unmuted yourself.
Yes. No, it's a very wonderful and a powerful presentation. At least it has revived us.
Okay.
Yes, and we are looking forward to that.
Do you have any DSD models that you present in Monsabombe?
Currently, it is just the CAG ones from the community. Yes.
Okay. All right, but are you doing the facility-based ones like multi-month dispensation? Have you been able to do that?
Yes, yes.
Okay. No, thank you so much for sharing your experience. We appreciate your comments.
Thank you very much.
Dr. Singini, I've seen you raise your hand. You would like to?
Yes, just a quick question to Dr. Mlenga. Thank you for the presentation. Doc, is there a DSD model that can be tailored to recipients of care that are undergoing or they're suffering from intimate partner violence? So just a quick synopsis is that there's a patient in Western Province whose husband was against her taking medicine, and the woman was actually being beaten and threatened to be chased out of the house. So is there something that we can do in such cases? Thank you.
Thank you very much, Dr. Singini. Very unique question, eh? Dr. Mlenga, would you like to hear from the network first, then you can come in on that one? Dr. Mlenga, are you able to hear us? So can you get any comments from the people that are on the call as we wait for Dr. Mlenga to come in? I know Dr. Bosco is here, also very involved in treatment and care. You may be able to come in and say one or two things to that effect. I know Dr. Muntali is also on the call. If you want to say something, you can go ahead and say something. Chamba, I've seen you raise your hands. Chamba, you can unmute yourself and make a comment.
Yes, thank you so much, Doc, and the great presentation from Dr. Mlenga there. Matthews from Kawe. So I just want to find out if we need to continue to promote community ART groups, the CAGs, in the advent of 6MMD. Yeah, I'm asking this because since the time we started the implementation of 6MMD, most of the groups which we formed disintegrated. Now, should we continue to promote the CAGs? Thank you.
Thank you very much. A very important question. Take a note, so we have two questions. Yes, Dr. Mlenga. Yes, Dr. Mlenga. Did you hear the first question?
Yes, I got the first question and I was actually talking to a muted microphone.
Oh, no, sorry.
Yeah, sorry, that happens. So let me start by mentioning that we have adopted, okay, the different DSD models from partners, okay. If I give an example, the CDU, okay, it is an initiative or an innovation of a partner called EQUIP, okay. The home distribution is an innovation of a partner called University of Maryland. Okay. You find that Fast Track, maybe it was initially implemented by a different partner like CIDAS. So we do encourage innovations and initiatives. And actually, we want to encourage our implementing partners out there to identify the needs in the community and then come up with some DSD model that are going to meet that need. Remember, I was emphasizing a model should be able to meet the needs of different individuals or groups of individuals. So if we see that IPV, intimate partner violence, is an issue in this community, okay, as partners, as MOH, we need to come up with a specific model where our recipients of care that are being subjected to that can receive help, okay? At least we can. So the examples that I have given are in no way exhaustive, okay? We are encouraging innovations, okay, coming up with different models, meeting specific needs of our recipients of care. I think that's the first one. I actually saw that case, and I think we should, as a team, try to find a way of meeting the needs of those recipients of care that are undergoing IPV. Okay. The second one, what was the second one on?
So the second one was that community RIT groups have lost favor following the 6 months MMD. So the 6 MMD. So they are asking whether there's need to continue mobilizing the people to participate in the CAGs.
Yeah. So as a facility, we should be able actually to be alive to the fact that a model should serve the needs of the recipients of care, okay? Before we had a 6 months MMD, and what we had was CAGs. That was maybe the best at that time, okay? And it was meeting the needs of the recipients of care at that time. Even at the national level, we have seen that now with the coming in of the 6 months scripting and dispensation, our recipients of care are preferring that. Okay. You cannot, again, tell this that you cannot cross from one model to the other. Okay, it's a preference by the recipient of care. Okay, so even in this day and age, okay, because there are some activities that happen in the CAG that may not be happening in the 6 months, months, whatever, scripting and dispensation. So if you see that there is no need, maybe you can say, let's stop. But otherwise, there are some people who want that psychosocial support that is provided in the CAG.
So I think that's well put, Dr. Meng. I think even the slides were able to say that a facility needs to assess its environment, assess its recipient, the needs of recipients of care, and be able to provide according to what is feasible in that environment, and be able to offer what the recipients of care would deem favorable for them. Because there are some, like you have said, who in a community RIT group, they usually go beyond just meeting for that. You might find it's actually an entrepreneurial group and they're providing different social support. So I think it has to evaluate our situation in the facility. Thank you very much, Dr. Mlenga. We've gone way over our time allocated. And so I saw a hand from Mukuka. I don't know if Mukuka, you've changed your mind, but I think you'll be one of our last people to ask a question and a comment. Would you like to unmute yourself and ask? So Mukuka, are you okay? Maybe your question was asked. Yes, Mukuka.
Okay, yeah, no, yeah.
I think you seem to have a very difficult network where you are.
Yes, I can comment, Doc. Good afternoon, everyone. Good afternoon.
Unfortunately, your network is breaking, so we can't hear you.
Okay, okay. Are you able to get me now?
Yes.
Okay, good afternoon, everyone. everyone. Good afternoon, Doc.
Good afternoon.
Yes, Doc, I wanted to raise this concern. I think it was clear on the part of the presentation that every issue was raised. But according to my observation, I think the issue also of client falling out of a model, I think should be raised, because there are instances where we give clients drugs, for example, cards. Then you find that when you start monitoring the other clients that will present with maybe core infections. So I think during the presentation, the issue of clients falling out on DSD models, I think it was not handled. Is it possible for a client to fall out, for example, if they present with a core infection or maybe with a comorbidity? That's the question I wanted to raise.
No, actually, you've raised a very important question, Mkuka. We appreciate. Dr. Mlenga, we talked about those that meet the criteria of being joining a DSD, but perhaps maybe we could amplify a little on those that might end up dropping off and how we can manage that process. Would you like to make a comment on that?
Thank you very much for raising that issue. That is very important that we address that issue if it was not clear from the presentation. So during a CAG session, there's usually some adherence support that is given, and there's also a quick symptom screening that is done. And remember, I said a CAG, it can be a healthcare worker led, but mostly their recipients, at least there's someone in charge of that CAG. So the documentation has to find its way back to the facility. And if from the symptom screening, you pick out something, that recipient of care has to be referred to the mother facility. So monitoring of the recipients of care in the CAG happens. It does happen, and if it reveals that there are some people who may require further investigations from the facility, they need to be referred to the facility.
Thank you very much, Dr. Mlenga. I think that being some of the final comments from the network, I just want to invite you to just make 1 or 2 comments as we wrap up, because we will end the meeting in a few more minutes. Dr. Mlenga, any final comments on this DSD?
Yeah, so like I said, people out there, they should identify what some of the needs for the recipients of care are in the different settings. Okay, me, I'm here at Ndeke House, not knowing what is happening, okay, in the community. I may have an idea of what is happening in the facility, but you are close to the community where our recipients of care are coming from. Okay. So we need submissions, we need ideas, okay? What is lacking, okay, for this community in this setting is this, and can we come up with a model that can respond to the needs of the people in this community? We may try to put up some write-up and also maybe engage one of the partners, okay? Because partners are there close to you, working with you. We can engage the partners or task one of the partners to say, how can we meet this need that has been identified in this setting, okay? And let's remember that DSD has to meet the needs of the recipient of care. Okay. It's not just to decongest the facility so that we can have more time on Facebook and social media, Okay, so that time should be reinvested into the care of recipients of care that have to be at the facility. I think that's what I can say for now. Thank you for listening to the DSD presentation.
Thank you very much, Dr. Mlenga, for taking time to come and make this presentation. I'm sure our network across the provinces have appreciated this very useful information and to improve in their service delivery. Thank you very much. There's a comment here that from Usiku that we just need to be careful as advised as we enroll clients into DSD. We need, as we know, monitoring their viral load becomes a challenge as they establish relationships with other health workers to collect drugs for them without labs, making the monitoring very difficult. Thank you very much, Busiku, for that comment. I think it comes at a very right time. And with that said, we want to thank you all for coming through. We will be meeting next week yet again for another session at 14:30, and we'll be looking at another very interesting topic. And this time we'll have everyone connecting in at the same time, and we appreciate everyone's effort. Thank you, Dr. Mlenga. Thank you to all those that connected. Have a very good evening. Thank you.